There's a wonderful attendance here today, almost a packed house. I'm very grateful for the invitation. Thank you to Peter and the committee and everybody in Epilepsy Ireland for inviting me here. It's always nice to come to Sligo, and it's always nice to come and talk at this conference. I won't tell you how long it is since the last time I spoke at this conference. It was quite a number of years ago. So I think something like this, it is nice to give you something that makes me sit down and think, okay, what am I going to do with this? How am I going to present this? And what are the top 10? I thought this might be useful. What are the real top 10? I don't know. And I'll work my way through it with you. And you might find my arithmetic is a bit faulty as we go through as well. And I suppose the way I came around to it was, well, what questions do parents and families ask me, particularly say at a first consultation? What are the questions that people ask? Or sometimes there's questions that they're worried about and they don't ask, and it comes up years later, things that people ask. So that's kind of how I've tried to focus this, is what families seem to want to know or what they're worried about or not reassured about. And that's kind of how I have gone about this. And I'm also very conscious when I'm talking to a group like this, I'm talking to a group largely of experts or people who know a lot about their family's epilepsy, their child's epilepsy, and a lot of what I'm going to say is stuff people know anyway, and I apologise for that in advance if I do so. One of the things people ask you, well, what caused it? And obviously we have many children, where we know exactly what caused their epilepsy. It might have been a brain injury or whatever, but we plenty where we don't, and we assume that most of that is genetic. And people say, well, there's nobody in my family that has epilepsy, and then that can be the case. You can have bad genes that come through families without affecting any known family members, and there are probably multiple genes involved with those genetic forms of epilepsy. There may or may not be a risk for other family members, depending on the kind of way that is inherited, but usually the risk is low. Usually it's in the order of 5% or less. And then I suppose what we've got a lot better at in the last 10 years or so is identifying some of these severe infantile genetic epilepsies, like difficult epilepsies beginning in the first year of life or the first month or two of life. And I can remember looking at these 20 years ago and saying to parents, well, I don't know what caused it, but we know how to treat it or work to try to treat it. And now, 20 years later, we have identified genetic cause for many of those. They don't necessarily come with a treatment attached, but they come with a lot of understanding, and I think that is valuable. And if you look at those severe infantile epilepsies, usually there's very little risk for that coming back in the family. It's usually a bad gene that arose in that particular child in their genetic makeup. So there are many more to be discovered. We haven't by any means discovered all of them, but so that's one of the things that is at the back of the people's mind. Well, what did cause it, or why did it begin now? And that's an even harder one. And mostly we don't know the answer, except we say, well, this kind of epilepsy usually begins at age 5, or this usually begins in a teenager, or this usually begins at age 1 to 2 years or whatever. But we don't really understand why. It's something to do with the reorganization of the developing brain, the environment, maybe hormones in the teenager, etc. So people do ask very appropriate and intelligent questions, and we don't always have very intelligent answers, but it doesn't mean we're not trying to answer them. So I think genetics is important, and I think it's a factor of all of us, different components, but the bottom line with genetics in epilepsy is that it is not always very predictable. It's not always very predictable how that is going to recur in a family. I'm just going to throw in a couple of examples. This is a guy who came to me at age 23 months, and he was having very long febrile seizures. Now, as you know, febrile seizures in children, we say, mostly febrile seizures, we say, well, this isn't epilepsy, this is just febrile seizures. Don't worry about them. Your child will grow out of them. We won't do anything about them. We won't put them on an anti-epileptic medication. And that is true for 90% of febrile seizures. It just so happened something was coming to the surface at that time. There was a group of neurologists in Tasmania who were doing a lot of, it was southern Australia, mostly based out of Melbourne. They were doing the research, but they identified this very large family in Tasmania where, if you look at this enormous family tree, and they have them all colour-coded, there were some, depending on the colour code on the various family members here, some of them would have just had febrile seizures. Some of them might have had generalised tonic-clonic seizures, full falling down. Some of them might have had absences. Some of them might have a thing called myoclonic astatic epilepsy, where they were having seizures where they fall to the ground, where they were having generalized tonic-clonic seizures, where they were having absences. So there were multiple different kinds of epilepsy happening in that family, some just febrile seizures on their own, some febrile seizures going on to generalized tonic-clonic seizures. So this guy's having febrile seizures going on to generalized tonic-clonic seizures. Let's check him for that gene. And that's the syndrome. It's called genetic epilepsy with febrile seizures plus, or I've seen it called generalized epilepsy with febrile seizures plus. And they have these multiple different kinds of seizures, different in different family members, but the common clue is starting out with febrile seizure and going into generalized tonic-clonic seizures. So we tested him for the gene. It was positive. I'm still looking after that guy now. He's a teenager and he's reasonably well controlled, and I would hope that he'd be kind of the same as his dad, that he will remain well controlled, certainly on medication for the foreseeable future, maybe a time in the future where maybe he can come off it, but he's reasonably well controlled. So that's just an example. And this is another example of a baby who had a very, very severe epilepsy in infancy. There's a thing called O'Hara syndrome, which is a disorder where you have multiple seizures in a newborn baby. You have this really abnormal EEG, which is just continuously showing these bursts of abnormal activity and then a flat gap and bursts again. And O'Hara syndrome had been around for a long time, and what did people know? O'Hara syndrome was bad news. It really was going to be difficult to control seizures in many cases, although you might, and that these children sadly were going to have developmental problems in the future and learning problems and learning disabilities. So at the time we said, look, this is what it is, we don't know the cause, we've done all the scans, etc. And then 14 years later, as these genes were identified, this particular gene came up, the STXBP1 gene, and we said, we were doing a genetic study in Temple Street at the time, and we identified that this guy had a defect in that gene, which is known to be one of the number of causes of O'Hara syndrome. And as it just so happens, he had done very well on vigabatrin, which is a rarely used anti-epileptic drug because it has some side effect issues, but he had done extremely well on it and he'd stayed on it all his life. And it just turned out this particular gene, they do well on vigabatrin. So it kind of reinforced, what we were already doing. It was enormously helpful for this family. Now, we didn't make his life any better when we found the gene, but the family just had a great sense of relief that now they knew what the cause of the problem was. And why? Why were they so relieved? I mean, you could ask why. Well, I think there's lots of mothers walking around when they haven't been told the cause, assuming the worst, and you might tell them it's not anything, but there's a lot of this nagging belief that something happened in the pregnancy or something happened at the birth. And I said, I've had parents ask me that question, and I've gone through it with them, and you don't necessarily completely reassure them when you go through it with them. And I've had people years later say, even though they never really asked the question, well, I always thought it was something in my birth, it was something in my pregnancy, or whatever. So when you can come back to them, you can say, no, this is what it was. It's enormously relieving and helpful for those families. And I've sat down with a number of these families with new gene diagnoses now, and as I said, an outsider might look at it and say, well, what good are you doing for these people? You are doing quite some good. And obviously the hope is that the more we discover about these genes, the more we come up with more useful treatments and ways to combat those specific genetic kinds of epilepsy. And there is some progress, although slow progress in those areas. So people often ask me that question, was it due to something at the birth? You know, my child needed a little bit of oxygen at birth, needed a bit of resuscitation, the APGARs were low, etc. And the answer is always, look, when a child gets a hypoxic brain injury at birth, we know. We have a very sick child who's having lots of seizures usually at that time, lots of other things wrong with the child in the intensive care unit, and the scan is usually very obvious. You can see a lot of hypoxic brain injury. That's what I say to people. So I suppose that's something I've learned over the years, and I think that's something that I like to bring back to parents and just kind of reinforce to them as well. This is something for doctors as well as for families around. So people say, we think you've got epilepsy, we're going to do an EEG, and an EEG is a very helpful test, but it's an ancillary test. And epilepsy, the end of it all, is not a disorder that's defined by an abnormal EEG, although there are certain forms of epilepsy where an EEG can absolutely nail the diagnosis. As you know, you don't have epilepsy after one event, you have an epilepsy after multiple events. And the abnormal EEG, there are people walking around with abnormal EEGs who've never had a seizure and who never will. In particular, say some family members of people who have genetic forms of epilepsy
may have abnormal EEGs, but that person may never have a seizure. Or they might have one and never have recurring seizures, which is epilepsy. So at the end of it all, it's about the story of the episodes and whether we believe those episodes are epileptic seizures. As you know, nowadays video is extremely valuable, and now that people have it in their pocket, in their mobile phone, that's very valuable. But I always want to hear the story first before I look at the video. I always want to get an extremely clear story of what's going on, and then the video is also enormously helpful. But the video on its own sometimes doesn't give you the whole story. And obviously, there are things like childhood absence epilepsy where an EEG pretty much always confirms the diagnosis. And if we record seizures during the EEG, that confirms the diagnosis. So there's exceptions to all these rules. And as you all know, you can have a normal EEG and still have epilepsy, particularly some of the focal epilepsy. So again, I'm sure most people in the room know all this stuff. This is an EEG of somebody with childhood absence epilepsy, just this generalized high spike wave discharge. This is an EEG of a patient of mine with a benign focal epilepsy, a kind of epilepsy that you grow out of. What's the other thing that comes up? I mean, we do a lot of telephone management about epilepsy via our epilepsy nurses, and there are things that come up all the time. And it's at the end of it all, these things are a judgment call that mostly are made by parents, and that's why we just have to have a conversation with parents and ask them to make these judgments. So many children who have particularly difficult epilepsy, children with well-controlled epilepsy may not have these problems, but what's very common are mild to moderate behavioural, learning, attention, concentration problems in children with epilepsy. So those problems are common intrinsically in that group of children, and there's some interesting studies where it's been noted that some of those issues are seen long before those children actually have epileptic seizures. Those problems are there. Now, there's absolutely no doubt that there's some anti-epileptic drugs that can make behaviour worse, that can make attention and concentration worse, and maybe have some impact on learning and cognition. There's no doubt that they can do. But they are rarely the main cause of those problems. They can sometimes be, but they are rarely the main cause. And I would usually say if those problems are existing in a child with epilepsy, the medication effect may be a factor, but it's probably 10 or 20% of the factor. And there are certain well-known drugs, and I won't go through all the medications with you, you know them, and there's some that are more known to do this than others. So I always try and get a baseline, number one. I try and get the families to know their baseline, because I don't know when they come in to see me in the clinic, I don't know what their behavioural baseline is. Only their parents really know that, and maybe teachers as well. And to get parents familiar with the baseline, give them time to settle in with the new medication. If there are behavioural problems, just be clear, is this worse than what it was before, etc. Is it due to the medication? Is it just the epilepsy? And the other thing that happens, and you see it particularly with epilepsy surgery, that sometimes you control the seizures and the mood and behaviour gets an awful lot worse. You know, sometimes the seizures were keeping a lid on the mood and behaviour. So you might put someone on an anti-epileptic drug or do something like epilepsy surgery that makes the epilepsy better and makes the mood, behaviour, all those kind of issues a bit worse as well. So it's a complex issue, it's a dialogue issue, but the bottom line is medications can be part of this issue, but they're by no means all of it or even most of it. Another thing that it's funny, then people years later might say to me, might have been looking after a child for years, and I'd say, well, maybe we'll take your child off their anti-epileptic medication. And I think people do retain a worry that being on a medication for a long time causes damage. I think that's something people think, or they ask, or I think it's at the back of many people's minds. And the answer is no, not for the majority of anti-epileptic drugs that we use. That's something. Some of the older ones can do that. But usually if we see side effects, we see them relatively early in the course of whatever we're doing, and we pay attention to them, I hope, and we listen to you, and we adjust the dose, or if it's a big problem, we take them off that medication, we try something else, etc. But there really, by and large, isn't any problem with being on an anti-epileptic drug for 10 years as opposed to 5 years, or 4 years as opposed to 2 years. And some of the older drugs, there might have been phenytoin, which is an old drug, but still a very effective drug, which we sometimes use. Vigabatrin, which I mentioned earlier, can cause a visual field defect, and that can be a permanent visual field defect. So there are some, but there's the small print ones nowadays. They wouldn't be commonly used anti-epileptic drugs. The other area, which again applies to most of the older drugs rather than the new ones, is the effect on bone metabolism and vitamin D, say something like carbamazepine, Tegretol, phenytoin, phenobarbital, and we know now that we need to keep an eye on bone metabolism and vitamin D in people who are on some of those older anti-epileptic drugs. And so, and they are examples of where if you were on them for a longer period of time, it might have more effect on your bone health if you didn't keep an eye on it and give calcium and vitamin D, etc., or do whatever you need to do. People still ask me about swallowing their tongues. I'm sure everybody in this room knows they don't swallow their tongues, so forgive me for putting it on the list. You all know, and you've probably many been at the excellent seminars on first aid and seizures that are run by Epilepsy Ireland, etc. And they don't. There's nothing that needs to be done in the course of a seizure, but I would still have families coming into me where I thought we had explained all this, and there's still people who think they need to do X or Y or Z. Buccal midazolam was mentioned earlier today by and large for a generalised tonic-clonic seizure lasting 5 minutes or longer. People often worry the lips turn blue during a seizure. That doesn't necessarily imply that the child is deprived of oxygen, and people are used to children in hospital getting administered oxygen, which we do because it's there, but there can be changes in circulation or perioral circulation. It doesn't imply that the child is suffering hypoxia during a seizure. You see a little bit of blueness around the lips. And the question comes up a lot, should my child have oxygen at home in the event of a seizure? And while I would accept that there may be cases where that is appropriate and necessary, that they're a minority by and large. The other thing that buccal midazolam is a hugely valuable rescue medication, which we get a lot of value out of, and families get a lot of reassurance and value out of. And the idea of it is it's absorbed rapidly through the mouth, and it's to prevent a prolonged seizure. I prescribe it for children who are having generalised tonic-clonic seizure lasting 5 minutes or longer. And then I would have some children who are having prolonged focal seizures. I would provide it for some of those, most of them probably. And sometimes we prescribe for children who are known to have clusters of seizures. And again, families know the pattern of their child's epilepsy, and they know that if Johnny has one on a Saturday morning, he's probably going to have 8. So we say, well, let's just nip in after number 1 and give him some buccal midazolam and prevent the cluster. But I think the point is that all of these are individually designed protocols that are agreed with the doctor looking after the child, and with the development of some knowledge of that child's epilepsy. I don't prescribe, and in general worldwide, one doesn't prescribe buccal midazolam for every child with epilepsy. One looks at what's going on. If that child is having prolonged generalised tonic seizures, one would always do so. But increasingly, one gets letters from school saying, this child has epilepsy, please prescribe buccal midazolam. And sometimes I'm writing back and saying, no, well, it's not necessary for this child. And that in generally makes everybody's life easier. But it is an issue that comes up frequently. This is one that people often ask me. And obviously we have many children that have nocturnal seizures, and then we have children who have never had a nocturnal seizure, but parents worry about this. They say, look, what if my child is having seizures in sleep and I don't know about it? And I suppose the answer is that usually if it were happening regularly or frequently, you would know about it. And the reality is, of course, if your child is known to have seizures in sleep, you may miss the odd seizure in sleep. If the child has never been known to have seizures in sleep, it's very unlikely that you're missing any seizures in sleep. And what should you do? I think what you have to do is practical and reasonable, and that's what most people agree. I think baby monitors are valuable, sound in particular, because you're asleep, you're not going to be watching the video usually, and if the child makes a noise in the seizure, alert you, and then if there is video with the baby monitor, my goodness, I'm way behind. Anyway, so I don't advise sleeping in the same room as parents, but obviously parents do that, and maybe doing it over a short term is good for everybody's mental health. It's not a good long-term plan. And there are these various new detection devices which I'm still learning about, and I think some of them may become very good, but at present, from what I read and what I hear when I go to conferences, not reliable as yet. And of course the big issue in everybody's mind is, could my child die in a seizure? Is there a risk of, and there is a risk of sudden unexpected death in epilepsy in children. It is less in children than in adults. It is more likely in certain specific genetic syndromes, in children who have severe uncontrolled epilepsy with generalised tonic-clonic seizures, or in children or teenagers who are not taking their medication. So all of these things are risks, but everybody takes risk in their life. You cross the road, etc., and it's all about balancing these things and having a balance in what you do in your life and not limiting somebody's life. So a lot of people ask me this question too. They say, well, is there anything we should be doing with diet? Yeah, a lot of people, and it's a very legitimate question. And the answer is no. No. And we all know that there is a very effective dietary treatment that Peter mentioned earlier for epilepsy, but that's a very organised, highly specified, unnatural, high-fat diet that is maybe very effective for epilepsy, but it's not something that it is casually done with minor adjustments in what your child is eating in the course of a day. There are families who believe that gluten-free diets have been helpful for their children's epilepsy. I have to say, still at this point, there is no medical evidence for that. It's not something I would usually advocate, but again, it's not usually a very harmful thing, though there have been incidents of harm in children and adults who were on gluten-free diets who were missing other essential components of the diet. Vaccinations are important, very important, should be avoided. There are some forms of epilepsy where seizures get triggered by fever, and I've touched on these earlier, Dravet syndrome in particular, and those children may have had their first seizures after vaccination. Well, actually, it was the fever from the vaccination that probably triggered the seizure, and it doesn't mean even those children shouldn't have their vaccination, but we might be a little bit more careful in how we're giving those, or sometimes give them in the hospital in those particular groups. But by and large, those vaccinations will not cause any brain injury. Even though your child has a neurological disorder, epilepsy, the vaccinations will not make the epilepsy worse. If your child gets one of these bad infections that are prevented by the vaccination, such as meningitis, etc., then your child will have a much worse brain injury from that. Or the community, because if the whole community immunity goes down, that causes more of these infections in the whole community. This is a quote from a former boss of mine, Charlie Barlow, who was the head of neurology in Boston. And he said all neurological conditions in children are preceded by head injury. And it was a bit whimsical. What he meant was every parent, when they bring in a child, remembers a head injury. They said he or she banged their head a week ago or a month ago or last year, and has that got anything to do with it? And usually no is the answer. And then the other question is, I'm not going to let my child play sports because I'm afraid if he or she bangs their head, they will get a seizure. And there is no whatsoever risk for that at all, by and large. And then there are obvious activities that have some risk. We things like climbing tall heights, etc. And I get lots of requests for letters for this and the other. And I try to think of ones I've declined. I did decline a request for scuba diving. I just thought that seems a bit iffy if you've got epilepsy. Driving go-karts, rock climbing. And maybe I was wrong. I probably don't know enough about those sports and the safeties in them. But by and large, we don't want to wrap kids up in cotton wool. We want to encourage them to be participating fully in physical activity and sports. A child may grow out of their epilepsy. I'm going to go a little faster here. There are some epilepsies that are guaranteed almost to grow out of, and there are others where there is less of a chance of that happening. I will always give children and teenagers that chance if things look favourable and have that conversation with families. My adult colleagues are a bit different because they're looking after adults who might be driving cars and holding down jobs and might not want to take any risk of seizure recurrence. So by and large, if somebody's free of seizures for 2 years or more, they have around a 70% chance of remaining seizure-free off medication. Some syndromes, as I mentioned on the other slide, can be close to 100%. Something like a focal epilepsy with an underlying brain lesion, it might be less than 50%. EEG we use to help us, but it's not always the main determinant. Excellent, apologies. Just about got in there. Sorry for slightly running over. Now, if any of you can count there, you'll see that there's 12 there, and I apologise for that. But anyway, I didn't leave them out. I hope that was helpful. Thank you very much. Okay.